All right, I want to thank you guys for allowing me to be here, and thank Professor Hintermann and Dr. Roots for coming and sharing their knowledge with us. So I'm just going to talk a little bit about my experience with the Hintermann H3 and kind of my background, my experience with other ankles briefly, and then go on into the patient-specific optics cutting guides. So I'm from Little Rock, Arkansas, practiced at Ortho, Arkansas, been there for about 14 years, almost 15 now. And my experience with total ankle replacement started in Charlotte, where I did my fellowship, Bob Anderson and Bruce and Hodges and Carol. And in fellowship, I was able to, learn the in bone at that time using the what we call the Big Bertha, the big guide, and also the star with Bruce. Bruce started doing some stars, so I was able maybe to do 5 with him. And then fellowship was over, and I had to go on to private practice. And since then, my experience started with the star and the in bone. So I was doing those simultaneously, both probably about the same amount, probably more star than in bone at that time, because I really, liked the mobile bearing concept. And then, but also I really liked the patient-specific instrumentation, and that came out with the in bone first, just a little bit before 2014. So kind of shifted and started doing more of that. And then the Infinity came out in 2014, and then I basically switched all my ankles, except for the ones that I still did in bone, big deformities, to PSI blocks. Kind of got away from the external alignment. Whether good or bad, that's what I did, and I had a lot of experience with it. And then I also tried the Vantage. I did about 35 of those. Didn't really like the way the tibia looked postoperatively. I saw a lot of radiolucency early on in a lot of my patients. I've had to revise a couple of those already. And so kind of shifted away from that. And I tried the Kinos. I still do some Kinos, which I like it, and they have PSI. Vantage has PSI. And then also started using the Hintermann, and I've done about 17 of those. So we're just gonna talk a little bit about my experience here. The star, overall, I think I had good results with it. I did about 25 of them, and so far I've revised only 2, and I have one other one that needs to be revised. Had him on the schedule, and he got sick and he had to cancel, but he is in the pipeline to be revised. One of them, it wasn't the first one that I revised, but I revised it for a fractured poly. This patient had very high ligamentic laxity. At the index surgery, I did the star and I did a brostrum. Thought that was enough. Probably wasn't enough. She was very, very kind of unstable. And I ended up, at about 5 years post-op, she fractured the poly, came in with her ankle all flopping around. And so I went back. The metal components were fine. Went back and did a subtalar fusion and exchanged the poly, and also did a brostrum split Evans procedure for her because she had a lot of subtalar instability as well. So this is not her case, but this is a case. This is probably the longest x-ray follow-up that I have. This is a patient who, she was probably 76 at the time of implant, maybe even early 70s, because she's like 80 something now. But I did a primary fusion at the same time I did the star. And this is her x-rays in 2012, and this is her x-rays last year in 2024. So she's still doing well on that side, has no complaints. Actually, her other side, she had arthritis, but she suffered from foot drop from back surgery or something like that. And so I was like, I can't put a total ankle in her, but I ended up putting the total ankle after I did a TTC fusion that went on to a non-union. And she's doing good with an in bone now, and using her dorsiflexion assist AFO brace. So it's just something I've done in some of my experience. And then I had another one that had loosening, converted to an in bone, and he got better. I suspected that his talus was loose, but when I got in there, I had to wail on it to get it out. So I think he was just a chronic pain patient. So moving on, I have pretty large experience with in-bone, and these are examples of the PSI blocks for the in-bone. One thing with the in-bone blocks, you find the sweet spot, find the alignment, set everything up, and then you cut through the actual cutting guides. So that's how you have to do that, along with the Infinity early on, and now they have their own cut-through guides. But that's one thing that Optics has that I really like. This is just a few cases. This is a case that this patient was, he was probably 58 at the time that Dr. Haddad did this implant. He initially had an ankle fusion, which I don't have those x-rays up. He had an ankle fusion done in Memphis, didn't like it. He had subtalar arthritis. Dr. Haddad took him back, did a subtalar fusion, then came back a few months later and did an Envision talus and an in-bone tibia. And then I think Haddad retired from his practice, and this guy had to find someone else. The guy lived in Memphis, so he ended up finding me. He came to me, and he was having pain in his ankle, and the pain was kind of all over, diffusely deep. He had restricted range of motion. He had a very large cyst here underneath these pegs, like very large, so large that I had to do some impaction bone grafting. But I took him back a couple years ago and did a revision on him. As you can see, he did have bone that was built up all the way across the front, which was impinging in the front. That was probably restricting some of his motion. And then I converted him to this Envision implant and an in-bone talus to kind of avoid this cyst. I used the longer stem on the in-bone, press fit. Now he's got probably 5 to 10 degree more range of motion, and he loves it. So he's doing well. And then this is just another example using the in-bone for ankle fusion takedown, one of my cases. So why patient-specific guides? The reason I like them is because it's very reproducible. It's just a study done by Greg Burlett and other docs, and they looked at the reproducibility and the alignment, and it's very reproducible. So, and that's why I kind of spent my practice doing that. This is just an example of one of my cases. This guy had an old tibia malunion, but overall his mechanical access was maintained, and I did an Infinity on him, and he did well. I've done 300 plus implants with Infinity and Prophecy, and basically these are why I did it. And overall, I've had pretty good success. I've revised only 6 that I know of, unless they went somewhere else to be revised, which I don't think they did. 2 of them were for infections. Both were late infections. One was hematogenous spread of strep, and I was able to convert him with a 1-stage, since the bacteria was just changed all the implants, did antibiotic cemented the implants, treated him for 6 weeks of IV antibiotics, and I was able to salvage him. He's about 2 years out from that. And then the other one was from after a colonoscopy. He got infected, but he sat at home for weeks and weeks. And so I had to do a 2-stage revision on him. And I think after I did it, he moved away and he went to Raleigh, Durham, so I still in the follow-up with the Duke guys. And then I had another one. The guy was playing basketball about just under 6 months post-op, and he went down, fractured his anterior tibia. The component kind of slid underneath the anterior cortex, and ended up converting him to an in-bone too. So anyway, I guess you're asking me why I should change. I've had a lot of success with the other stuff, but I wanted to try something new and get out there and do some more stuff. I felt that I was doing kind of the same thing over and over. It was reproducible, but I also felt that I had some early success with mobile bearing implants, and you guys have great follow-up and great data. So I elected to start trying the Hintermann. This is just one study out of Duke showing mobile bearing versus fixed bearing implants, that they basically had the same results in their follow-up. I think they won the Roger Mann Award or something with this article. So anyway, that's just more evidence that you probably do both. So what do you need for a total ankle replacement? You need to respect the anatomy, biomechanics. It's obviously a small joint, small approach, small window, as we've seen today in the lab. And you want to create minimal damage to the soft tissues, restore the biomechanics in the axis of rotation, and you want it to last over time, right? So I think what I've learned over time is that sometimes maybe I don't restore everything that I need to, but I try to. And in some of the cases that may have continued pain, should have been looked at a little bit closer in pre-op, you know. But for the most part, I do my best at it and try to get it right. So obviously, Dr. Hintermann went over all the success of the Hintermann. I don't really have to repeat it, but obviously his series of 683 patients, 86% survivorship at 15 years is really excellent. So I think his implant is really good, and we should strive to use it right, correctly. So the concepts, he kind of went over all this. It's an anatomical design, anatomical resurfacing of the tibia and the talus, and then the polyethylene insert has, you know, overall maximal contact and parallel interfaces. It shows good preservation of the anatomy. It preserves bone stock, keeps the ligaments, and it's obviously conical shape, and you can see that. And he talked about all that earlier. So obviously it is a mobile bearing, and then also they have the fixed bearing H2. So this is my very first Hintermann case. Dusty was there with me. He came down. We did a lab in the office. Did we do it the night before? I can't remember, but I think we did it the night before the surgery.
We did it, and it was a couple weeks later.
A couple weeks later, I remember a month later. Yeah, he came back twice. So he was there with me. He, you know, taught me how to do the procedure, and overall, I felt that it was a success. You know, just to critique my x-rays, maybe I should have removed this screw here and got my implant a little bit more medial, but overall, I think it's pretty good alignment. And it was very reproducible. I think I did the procedure in less than an hour and a half. And then in my second case, which was shortly after that, you know, I haven't done any major deformities with it yet, but pretty straightforward. Did the procedure. You can see a little posterior subluxation, more posterior wear. I got it centered pretty well, I felt. Maybe could have gone a little bit bigger with the posterior coverage, but I think some of that bone is just kind of built up over time. And then this is a case of some mild valgus deformity that I did with standard instrumentation. As you can see, I was able to make standard bone cuts and restore his anatomy. I don't think I did any other procedures with it, and his alignment looks pretty good. And then here's another valgus deformity. As you can see on the pre-op x-rays, patient also has, you know, midfoot arthritis and some hindfoot arthritis. And, you know, I was probably prepared to do a midfoot arthrodesis, but I elected not to during the procedure, and hopefully that didn't come back to bite me. But I thought I developed, you know, was able to get good, stable over alignment. The joint was stable, and we'll see how they do in the long term, you know.
It's nice to see with the tension of the ligaments how the arch has changed.
Yeah, it has kind of restored.
Position, so that's typical in valgus anchor.
Mm-hmm.
So in valgus anchor we tend to put a bigger insert to tension more.
Mm-hmm.
The opposite in varus, you see when you put the thicker in there, then you got the opposite effect.
Yeah. Would you have done the midfoot fusion, maybe? No?
I cannot say on the X-ray. But
Yeah, I don't have the good x-rays.
What you can, with a Salzman, you could have planned maybe an intraoperative to make a sliding.
The slide, yeah.
Maybe,
And I usually...
you cannot see, but maybe in the moment you pick up,
Lift the leg, look at the heel.
Yeah.
I usually
That's the
do
only
that.
thing, because it looks like it's really stern valgus, but yeah, but it's very well centralized.
Yeah, I mean, if you look at it now, though, I mean, on the AP ankle view, the heel is not sticking out the side.
The subtalar joint is again open and nice.
Open,
Yeah.
yeah. Okay. And then here's a 62-year-old golf pro. He's had an in bone on the other side in another state. He moved to Hot Springs, Arkansas, and he works down at the country club. One of my anesthesiology colleagues, it's his dad's neighbor, and he asked me to take a look at him, and he came to me, and I think he's in the post-approval trial, and he had the end bone, and he elected to allow me to do the Hintermann on him. So we'll see how he does compared to his end bone, which is about 8 years out. So if you can see, there is some lucency here on that end bone, which I see a lot of. I see a lot of that on my infinities, but if they're not painful and they're doing okay, I just let it ride and go with it. But early in my practice, I kind of chased some of the cysts and tried to bone graft them, but you know what? It really didn't make any difference. So, like, if it doesn't hurt, let's leave it alone. And this is just another case of, probably just mild valgus deformity in a slightly overweight female that I did a primary Hintermann on with standard instrumentation. Yeah, I think that the alignment looks pretty good. So, and then here's one of my complications. This is a 76-year-old diabetic, thin guy, active. He, has farm animals, all that stuff, does stuff with his wife. He came to me, and we talked about total ankle replacement. He is a well-controlled diabetic, hemoglobin A1C of 5, very active. And we signed him up for a total ankle replacement, actually put him in the study. And fortunately, he had overall decent alignment, but he had varus. And what I think I could have done better with him, instead of doing the deltoid release, maybe do the osteotomy. I don't have any intraoperative pictures of him, but I think that's the problem. You can see how it shifted a little bit medial.
The tail is sitting high, because the tail is...
High?
It's too high here.
Too high? I didn't pound it down far enough, you think? Or maybe my cut's too short?
Yeah, okay, but that is also not a lateral view, because
Yes, it's rotated.
You can see it's very high.
Yeah. Okay. So anyway, he came back to me at 2 weeks, and he wasn't infected. And then he went home. We took his sutures out. I put him in a boot walker, allowed him to start doing some weight bearing. Then he came back to me like 5 days later with MRSA infection. So I tried to do a washout poly exchange and salvage his metal. Unfortunately, we did 6 weeks of IV antibiotics, turned the IV antibiotics off, and he came back about 2 weeks later. So I had to take him back, and at this point I did a 2-stage revision. I didn't make the sweet little shaped implants, which I probably should have at the time. I should have done that, because when I removed it, his implants were well fixed. Some of the bone broke off, like the talus came off with it, a little bit, which is crazy in just a few weeks.
We always made...
Well, not a few weeks. Actually, it was like 2 months because he had that
We
antibiotic.
always make two components, like
The
an ankle,
prosthesis.
because otherwise we cannot take them out after 2-3 months. Is impossible, and they destroy everything.
Yeah, and
And they can also move a bit with two, and that is less stress, or that they don't sink so much.
so we did 6 weeks of IV antibiotics, obviously the antibiotic cement, and I let him start walking on it. He kind of tore the bone up a little bit. He broke the cement up, and I got CT scan, and I elected to do a end bone revision for him. So he's had it, that was about 6 months after the infection. So, he's hadn't recurred. His infection's doing great. He's probably about 6 months out now from the reimplantation. We'll see what happens. He's off all antibiotics.
What would you do if the MRSI comes back?
Comes back again?
You don't have many options left, right?
Yeah, not a lot.
It's a lot of bone.
Let me try fusion potentially, if you can clear it, and or amputation. Hopefully it doesn't happen for him, because he has a bad knee. He needs to get that replaced. He has the other side, the other ankle needs to be replaced as well. So hopefully keep our fingers crossed, say some prayers, and he'll continue to be infection free. All right, so there's another case. I just did a primary tenonavicular joint arthrodesis and a H3 at the same time. I think this patient's in one of the studies, in the study as well. And overall, that patient's doing well and not having any problems. So hopefully they'll continue to do that. So why I like the Hintermann total ankle replacement, obviously minimal bone resection. It's a mobile bearing or fixed bearing, so you have options. It has the anterior flange on the tibia, which I really like. So when I put the implant in, I know it's flush to bone. I'm not worried about it going too far back or too far forward. I know where it finds its sweet spot, so I really like that. And then another thing I think, and I don't know in your practice, do you ever see like bony overgrowth anteriorly? You probably don't with that metal flange.
No, I tell you, the good thing is this provides so much instability to flange because we did many histological analyses and you see that great osseointegration along the flange. And we have 3-plane osseointegration. And when you saw now your cases, I didn't see any case with any osteolysis or loosening signs, lucency signs.
They're all good.
And that is something that makes me so confident with this ankle. This is also probably the reason why you have good long-term results because it's really a stable interface.
Yeah. Anyway, so that's what I like. So in summary, obviously the Hintermann total ankle replacement's got proven results. It's a resurfacing concept. I like that. You can weight bear them quickly. I usually let them start walking on it 2 to 3 weeks, not right away. Maybe I should. I do ask them to load it though in the splint. I put them in a splint. Y'all put them in a cast postoperatively?
We use a vacuum pit.
A what?
This like a boot.
A boot?
A boot.
We use a boot.
Yeah,
No splint. You
in
get
the night. In the night.
in the
In
night.
the night. We use
Okay.
a splint in the night, and then it's a training process for them. But part of this, the osseointegration has to be stimulated since the very beginning. So
Mhm.
you need to charge.
To weight bear.
Yeah, because that is the contact makes. Even when you see some little line that you can feel like it was not so impacted in the OR, immediately when they begin to charge, wearing
It draws it up.
drops in. So
Okay.
it's very important.
Well, I'll change that. I'll have them start weight bearing in the boot. Well, I like to put them in a splint for 2 weeks, like a plaster
That's
splint.
okay if it makes you feel
10 to 14 days, just for the incision to heal. But anyway, so stable implant, stable interface. That's why I like it. No stress shielding. So we're just going to briefly review the Optics PSI. It's new, and I really like it. I've only used it 3 times, but so far so good. And we'll talk about how it's used here. It's upgraded. Obviously, you have the patient-specific blocks for the tibia and the talus. You can cut through the blocks made out of a nylon material. You get the custom alignment. You review the plan and all that. And it, in my hands, I think it saves operative time. You don't have to fiddle with the external alignment guide. And I can plan it out ahead of time and execute it when I get in the operating room. So, not everybody needs it. And I don't think I'd necessarily have to have it either, but I think it'll speed me up and maybe a few less cuss words during my operation. So, here's just some overview of it. You can see the tibia pinned down, the talus top cut pinned down, and then the chamfer cutting block pinned down here. The process, basically, you get the CT scan in the office per the protocol. And I think you should have your techs, obviously they scan from the knee all the way down. And then you should have your techs ask the patient to put it up closer to 90 degrees if they can. And then you do your alignment with the plan, and the surgeon approves it. Then they make the implants, and they send it to you for surgery. So just an overview, obviously, you have identifiers right, left. They send you the cutting blocks, and they also send you a 3D model of the bone, the tibia and the talus, to match it up, make sure everything's correct. And then the way you do the alignment, you have this little tube that you put in the nylon implant to make sure you're centered and AP and perpendicular to the cutting blocks. And then you also have a little pin for the chamfered cutting block as well. You can see the implants, the cutting blocks matched up against the 3D printed models. And then what you have to do, once you get the model, you make sure it's correct. You put your alignment post with your little connector, assemble that, and that clips into the front of the implant. We'll see that here in a little bit in the lab. And then you start your procedure. After you get your exposure, you first find the sweet spot wherever it matches up, and then you pin it down anteriorly, and then you put your post on, and you check your AP alignment in this X-ray simulation. And then once you have the oblique pins in, you check the lateral with the angel wing, just like you do on the standard instrumentation. You can see for the, you got the short bars and the long bars for your resection height. For the H3 is the short, obviously the long is the H2. And once you make sure you're in the correct position, you go ahead and make your bone cuts. And then once you make your bone cuts, you remove the tibia bone piece. And actually, when you make the bone cuts, you actually do it through this block. And then you do your tailor block, superior cut, pin it down. It's just anatomic fit. I do find that you need to make a little extra exposure distally, really get those soft tissues retracted, especially for these lateral and medial pins, especially lateral. So be very careful. The neurovascular bundle is right there. I actually had an injury with one of them, so be very careful with the neurovascular bundle when you're making that lateral cut, lateral chamfered cut. And then obviously you get the surgical overview, check the AP, you put a pin down the center that kind of shows you where that resection height is, and then you check the lateral with the angel wing to determine your cut level matches the plan. And then go ahead and pin your gutters and put your two anterior pins and make the bone cut. And then you leave the two anterior pins, take all the other pins out, slide the superior cutting block off, and then put this on. Should fit anatomically, just like the other one. And then you could also put the little pin in the side here to check your alignment to make sure you're centered on the talus where you want to be. And that just illustrates it. And if you think you're in the right spot, you go ahead and screw it all down and do your finishing. You can make your medial and lateral cut. What I like about it is when you make the cut, it's just like the metal block. You go down all the way to the pin, all right, and cut back to it, all right, on both sides. So it gives you a stop in it where, before you have to kind of eyeball it, go to where you think the depth's supposed to be and pull back to you. This actually gives you a good hard stop in most cases for that. Then you make your posterior cut, and then you make the first anterior chamfered cut with the reamer. And then you take all that out, and this is showing your lateral cuts. And then the only part that you actually have to use from the standard instrumentation, besides the chisel and the distractor, really is the anterior, the trowel. And you have to basically take the bone off just like you would with the standard technique. And you can use this reamer, which if you want to, but I like to do the fan technique. And then ream for your anterior pegs. And if you got all your alignment right, go ahead and implant. Well, actually, you implant your total ankle replacement press fit, just like you do in all the other cases. So this is just some optic 3D cases that I did. This is two of my cases using the optic cutting block. Overall, looking at the alignment, I think they came out pretty good. This is a varus. I think I did a deltoid peel. I didn't do the osteotomy there. So I may see some drift here again in the future. So we'll see how that goes. You think the syndesmosis is okay?
The syndesmosis is a bit suspicious.
It's the whole block is, you see the whole line black in here. Inside.
Right here?
Yeah, when you see here, this space.
You think it's too much space?
It's this shadow, like a shadow you see there.
Mhm.
Sometimes it's a sign.
Okay. All right. I'll have to follow them close. So only on that view? I guess you can't tell till you correct it, huh?
It's not the same view.
Not same view, no. Okay. And another thing the optics helps you out with is hardware that you need to remove. It tells you in the plan what you need to remove. This is one that I didn't do with the optics. I just did a standard technique, but he had a lot of hardware. I only had to remove, I think, 2 screws, and I was able to get his implant in. So, and this is done with standard instrumentation. So this is what the plan kind of looks like. They give you a tibial summary. It tells you your implant sizes. Obviously, you have to review all this and approve it before they make everything, but it gives you a list of all the sizes and what you need. And then it shows you the plan cutting alignment, and it shows you the guide placement and everything else, and then it shows you your resection height on the lateral view as well. So basically, you got to try to match the plan. Your rep should be able to have that next to you. You can review it while you're doing the operation on an iPad. And then this is the talus plan. Similarly, you see, where the implants want to be and need to be. It tells you the sizes and everything, and it shows you a map of where everything should sit as it's planned. And then this is one of my cases that I showed earlier, same case, but this was the final implant, plan versus the product. So we'll see how it goes. But I think it was pretty matched up. And this is another case that I got actually from Dr. Clayton. I got it from him mainly just to look at pictures. I didn't have any intraoperative pictures, and he did a case like Monday, so he sent me all the stuff, and he's in Fort Smith. I helped train him a few months ago, and he's done a few Hintermann since then. But this is his plan. As you can see, it shows, they also have a hindfoot alignment view, shows you the hardware, and it tells you, at one of these pages, it tells you what has to be removed. And he ended up removing all of it, but just kind of to review it. Everything looks good. These are some intraoperative pictures of him matching it up to the 3D models, and then this is him putting it together. Got his fingers in it, lining it up. You could probably go ahead and put the pin in once it feels good, because you got multiple pin sites that you can use. You could use one of the oblique pins to hold it in place where you get your alignment and check it. And then I didn't have a good lateral view, so I used one of my fluoros from another one, but obviously you want to check the lateral view. Then you make your tibial bone cuts and remove the bone. One thing you can't do, which is a negative for the optics, is you can't lever that bone out with the chisel. So you have to improvise because you don't have that metal piece there. But I'm able to get the bone out. So it's maybe a little bit harder, but not much. And this is the talus plan that he had. And this is him checking the implant and checking it with the angel wing, checking the AP view with the pin in it. And you can see the cut line there visible. And then this is the chamfer block pinned down and with the lateral guides in, and the screws are in as well. And these are his final x-rays. And one thing I question, I'm like, I don't know why. It seems to me like his cut is here and his tibial implant is a little positioned lateral. If you look at the plan, it looks like the tibia was supposed to be all the way to the cut line here, and the talus should match it. So a little discrepancy there, but it was a 5 and y'all put a 4? Oh, you put a 5, okay. Anyway, maybe you could have moved it a little more medial, but it seems to be lined up with the talus. And that's just fluoro in the OR anyway, so it's not standing x-rays. So why do I like or claim to like the optics? Obviously, it's easy to use. Most of the work is done through the guides, which you don't have to change a whole lot of things. So once you get it in place, you make your cuts. You don't have to put the cutting block on like some other companies that have them early on. And then I think it'll decrease my operative time and we'll have a reproducible plan. And that's it. Thank you. Any questions?